The management of nausea and vomiting of pregnancy and hyperemesis gravidarum. Green Tab Guideline number 69, June 2016. Introduction and Background Epidemiology. Nausea and vomiting of pregnancy, or NVP, affects up to 80% of pregnant women and is one of the most common indications for hospital admission among pregnant women, with typical stays of between 3 and 4 days. For this guideline, NVP is defined as a symptom of nausea and/or vomiting during early pregnancy where there are no other causes. Hyperemesis gravidarum, or HG, is a severe form of nausea and vomiting of pregnancy which affects about 0.3 to 3.6% of pregnant women. Reported hyperemesis gravidarum recurrence rates vary from 15.2% in a Norwegian hospital registry study to 81% if using self-reported diagnosis. The etiological theories for nausea and vomiting of pregnancy and hyperemesis gravidarum range from fetoprotective and genetic to the biochemical, immunological, and biosocial. They are primarily thought to be associated with rising levels of beta-human chorionic gonadotrophin, or HCG hormone, and conditions with higher HCG levels such as trophoblastic disease and multiple pregnancy have been associated with increased severity of NVP. Diagnosis of nausea and vomiting of pregnancy and hyperemesis gravidarum. How is NVP diagnosed? NVP should only be diagnosed when onset is in the first trimester of pregnancy and other causes of nausea and vomiting have been excluded. Onset of nausea and vomiting of pregnancy is in the first trimester, and if the initial onset is after 10 plus 6 weeks of gestation, other causes need to be considered. It typically starts between the 4th and 7th weeks of gestation, peaks in approximately the 9th week, and resolves by the 20th week in 90% of women. How is hyperemesis gravidarum diagnosed? Hyperemesis gravidarum can be diagnosed when there is a protracted NVP with a triad of more than 5% pre-pregnancy weight loss, dehydration, and electrolyte imbalance. How can the severity of nausea and vomiting of pregnancy be classified? An objective and validated index of nausea and vomiting, such as the Pregnancy Unique Quantification of Emesis, or PUQE score, can be used to classify the severity of NVP. Objective, validated measures for the severity of nausea and vomiting include the Rhodes Index and the PUQE Index. The Rhodes Index was originally validated to measure nausea and vomiting in chemotherapy patients, including assessment of physical symptoms and the resulting stress, but has subsequently been used for NVP. A shorter disease-specific questionnaire, PUQE, was developed by the Mother Risk Program, an NVP helpline in Canada, which highly correlated with the Rhodes Index. The PUQE, or the Pregnancy Unique Quantification of Emesis, was modified to include symptom profile over the previous 24 hours, including a well-being score that correlated with hydration status, and more recently, over a longer period of time. The PUQE score can be used to determine whether the NVP is mild, moderate, or severe, and can be used to track progress with treatment. What initial clinical assessment and baseline investigations should be done before deciding on treatment? Clinicians should be aware of the features in history, examination, and investigation that allow nausea and vomiting of pregnancy and hyperemesis gravidarum to be assessed and diagnosed and for their severity to be monitored. Table number 1. Features in the history, examination, and investigations to monitor severity and other causes. History. Previous history of NVP or HG. Quantify severity using PUQE score, nausea, vomiting, hypersalivation, spitting, loss of weight, inability to tolerate food and fluids, effect on quality of life. History to exclude other causes, abdominal pain, urinary symptoms, infection, drug history, chronic Helicobacter pylori infection. Examination. Temperature, pulse, blood pressure, oxygen saturations, respiratory rate, abdominal examination, weight, signs of dehydration, signs of muscle wasting, and other examination as guided by history. Investigation. Urine dipstick. Quantify ketonuria as 1 positive ketones or more. MSU, urea and electrolytes, hypokalemia or hyperkalemia, hyponatremia, dehydration, renal disease, full blood count, infection, anemia, hematocrit, blood glucose monitoring, exclude diabetic ketoacidosis if diabetic, ultrasound scan, confirm viable intrauterine pregnancy, exclude multiple pregnancy and trophoblastic disease. In refractory cases or history of previous admissions, check TFTs, hypothyroid or hyperthyroid, LFTs, exclude other liver disease such as hepatitis or gallstones, monitor malnutrition, calcium and phosphate, amylase, exclude pancreatitis, ABG, exclude metabolic disturbances to monitor severity. Reported hyperemesis gravidarum recurrence rates vary from 15.2% in a Norwegian hospital registry study to 81% if using self-reported diagnosis. However, the incidence of hyperemesis gravidarum reduces in second pregnancy if there is a change in paternity, 10.9%, compared with no change, 16%. Nausea and vomiting of pregnancy and hyperemesis gravidarum are associated with hyponatremia, hypokalemia, low serum urea, raised hematocrit, and ketonuria, with a metabolic hypocholeremic alkalosis. If severe, a metabolic acidemia may develop. In 2/3 of patients with hyperemesis gravidarum, there may be abnormal thyroid function test based on a structural similarity between thyroid stimulating hormone and HCG with a biochemical thyrotoxicosis and raised free thyroxine levels with or without a suppressed thyroid stimulating hormone level. These patients rarely have thyroid antibodies and are euthyroid clinically. The biochemical thyrotoxicosis resolves as the HG improves, and treatment with antithyroid drugs is inappropriate. Liver function tests are abnormal in up to 40% of women with HG, with the most likely abnormality being a rise in transaminases. Bilirubin levels can be slightly raised but without jaundice, and amylase levels can be mildly raised too. These abnormalities improve as the hyperemesis gravidarum resolves. An ultrasound scan should be scheduled to confirm viability and gestational age and to rule out multiple pregnancy or trophoblastic disease. Unless there are other medical reasons for an urgent scan, this can be scheduled for the next available appointment as long as the nausea and vomiting of pregnancy has resolved with treatment. What are the differential diagnoses? Other pathological causes should be excluded by clinical history, focused examination, and investigations. Other pathological causes of nausea and vomiting include peptic ulcers, cholecystitis, gastroenteritis, hepatitis, pancreatitis, genitourinary conditions such as urinary tract infection or pyelonephritis, metabolic conditions, neurological conditions, and drug-induced nausea and vomiting. Severe abdominal or epigastric pain is unusual in NVP and HG and may warrant further investigation of serum amylase levels and an abdominal ultrasound and possibly esophageal gastroduodenoscopy, which is considered safe in pregnancy. Chronic infection with Helicobacter pylori can be associated with nausea and vomiting of pregnancy and Hyperemesis gravidarum, and testing for H. pylori antibodies may be considered. What is the initial management of nausea and vomiting of pregnancy and Hyperemesis gravidarum? How should the woman be managed? Women with mild NVP should be managed in the community with antiemetics. Ambulatory daycare management should be used for suitable patients when community or primary care measures have failed and where the PUQE score is less than 13. Inpatient management should be considered if there is at least one of the following: continued nausea and vomiting and inability to keep down oral antiemetics, continued nausea and vomiting associated with ketonuria and/or weight loss greater than 5% of body weight despite oral antiemetics, confirmed or suspected comorbidity such as urinary tract infection and inability to tolerate oral antibiotics. Women who have vomiting but are not dehydrated can be managed in the community with antiemetics, support, reassurance, oral hydration, and dietary advice. If women are unable to tolerate oral antiemetics or oral fluids, then ambulatory daycare management, which provides parenteral fluids, parenteral vitamins, multi and B complex, and antiemetics is appropriate if local resources allow. Various regimens have been shown to be effective. Ambulatory daycare management is associated with high patient satisfaction. Women who have recurrent NVP or HG, despite adequate ambulatory daycare treatment, should be managed as inpatients due to the associated complications, in particular electrolyte imbalance and nutritional deficiencies. What therapeutic options are available for nausea and vomiting of pregnancy and hyperemesis gravidarum? What is the safety and efficacy of pharmacological agents? Antiemetics. There are safety and efficacy data for first-line antiemetics such as antihistamines, H1 receptor antagonists, and phenothiazines, and they should be prescribed when required for NVP and HG. Combinations of different drugs should be used in women who do not respond to a single antiemetic. For women with persistent or severe hyperemesis gravidarum, the parenteral or rectal route may be necessary and more effective than an oral regimen. Women should be asked about previous adverse reactions to antiemetic therapies. Drug-induced extrapyramidal symptoms and oculogeric crisis can occur with the use of phenothiazines and metoclopramide. If this occurs, there should be prompt cessation of the medications. Clinicians should use antiemetics with which they are familiar and should use drugs from different classes if the first drug is not effective. Metoclopramide is safe and effective, but because of the risk of extrapyramidal effects, it should be used as a second-line therapy. There is evidence that ondansetron is safe and effective, but because data are limited, it should be used as a second-line therapy. Because different drug classes may have different mechanisms of action and therefore synergistic effects, combinations of drugs from different classes should be used in women who do not respond to a single antiemetic. Furthermore, Persistent vomiting may mean that oral doses of antiemetics are not absorbed, and therefore the intravenous, rectal, subcutaneous, or intramuscular routes may be necessary and more effective. Due to the risk of extrapyramidal effects with metoclopramide, it should be used as second-line therapy. A review of metoclopramide conducted by the European Medicines Agency Committee for Medicinal Products for Human Use has confirmed the risk of short-term extrapyramidal disorders and tardive dyskinesia, particularly in young people. The review recommends metoclopramide should only be prescribed for short-term use, maximum dose of 30 mg in 24 hours, or 0.5 mg per kilogram body weight in 24 hours, whichever is lowest, and maximum duration of 5 days, and that intravenous doses should be administered by slow bolus injection over at least 3 minutes to help minimize this risk. Dystonic reactions have been shown to be significantly less common in non-pregnant patients receiving a slow infusion as opposed to a bolus injection of 10 mg of metoclopramide. Studies on the safety of ondansetron are mixed. The use of ondansetron should be limited to patients who are not adequately managed on the aforementioned antiemetics and preferably used after the first trimester of pregnancy. Pyridoxine. Pyridoxine is not recommended for nausea and vomiting of pregnancy and hyperemesis gravidarum. A matched non-randomized study demonstrated that the combination of doxylamine and pyridoxine was significantly more effective than pyridoxine alone. Corticosteroids. Corticosteroids should be reserved for cases where standard therapies have failed. Corticosteroids should not be used until conventional treatment with intravenous fluid replacement and regular antiemetics has failed. The suggested dose is intravenous hydrocortisone 100 mg twice daily, and once clinical improvement occurs, convert to oral prednisolone 40 to 50 mg daily, with a dose gradually tapered until the lowest maintenance dose that controls the symptoms is reached. The suggested dose is intravenous hydrocortisone 100 mg twice daily, and once clinical improvement occurs, convert to oral prednisolone 40 to 50 mg daily, with a dose gradually tapered until the lowest maintenance dose that controls the symptoms is reached. In most cases, prednisolone needs to be continued until the gestational age at which hyperemesis gravidarum would have typically resolved, and in some extreme cases, this occurs at delivery. Diazepam. Diazepam is not recommended for the management of nausea and vomiting of pregnancy or hyperemesis gravidarum. What is the best rehydration regimen for ambulatory daycare and inpatient management? Normal saline with additional potassium chloride in each bag, with administration guided by daily monitoring of electrolytes, is the most appropriate intravenous hydration. Dextrose infusions are not appropriate unless the serum sodium levels are normal and thiamine has been administered. The most important intervention is likely to be appropriate intravenous fluid and electrolyte replacement. There is no evidence to determine which fluid regimen is most appropriate, but given that most women admitted to hospital with hyperemesis gravidarum are hyponatremic, hypocaloremic, hypokalemic, and ketotic, it seems appropriate to use normal saline and potassium chloride. Dextrose-containing solutions can precipitate Wernicke's encephalopathy in thiamine-deficient states. Hence, each day, intravenous dextrose is administered high, for example, 100 mg. Doses of parenteral thiamine should be given to prevent Wernicke's encephalopathy. Appendix 4 provides a summary treatment algorithm for nausea and vomiting of pregnancy and hyperemesis gravidarum. Which complementary therapies could be helpful? Ginger. Ginger may be used by women wishing to avoid antiemetic therapies in mild to moderate nausea and vomiting of pregnancy. No increased risk of major malformations has been reported with use of ginger. However, one review highlighted potential maternal adverse effects, including an anticoagulant effect, stomach irritation, and a potential interaction with beta blockers and benzodiazepines. Acustimulations, acupressure, and acupuncture. Women may be reassured that acustimulations are safe in pregnancy. Acupressure may improve nausea and vomiting of pregnancy. Acupuncture is safe in pregnancy. A systematic review has addressed the efficacy in NVP of acustimulations, for example, acupuncture, acupressure, and electrical stimulation at the pericardium 6, PC6, NAG1 point. PC6 or pericardium 6 is located about 2.5 finger breadths up from the wrist crease on the inside of the forearm between the tendons of palmaris longus and flexor carpi radialis. Hypnosis. Hypnotic therapies should not be recommended to manage nausea and vomiting of pregnancy and hyperemesis gravidarum.